Hello, my name is Dr. Ukiri Richard. Today we are continuing our podcast on basic cardiology, and we are going to discuss rapid progressive dyspnea. The case we are using today is an 80-year-old patient, female patient, that was brought into your accident and emergency room. 10 days ago, she had an arthroscopy of the right knee with partial resection of the internal meniscus. Post-operatively, she started feeling shortness of breath and weakness. But based on her own wish, she never wanted any tests to find the cure. She was discharged 2 days after the operation, after the procedure. 5 days ago, she had a strong retrosternal burning pain for the first time, and the breathlessness has been worsening. Breathlessness means shortness of breath. The emergency doctor that saw her gave her 500 milligram aspirin and 5,000 international units of heparin. In the physical examination, you noticed a 3/6 hollow systolic murmur in the fourth left parasternal intercostal space. The intensity changed with inspiration and respiration, but there were no radiation to the axilla. On thorax palpation, you noticed a mild parasternal heave. There were bilateral crepitation in both basally. At rest, the blood pressure measured was 120 to 140 millimeters of mercury systolic. The heart rate was 90 per minute. There was jugular venous congestion bilaterally. So my question now is, what differential diagnosis are you thinking of with these auscultation findings? Well, looking at the history, I have two possibilities. It could be an ischemia-induced mitral valve regurgitation. Well, typically here you normally pick up the murmurs around the 2 to 3/3 intercostal space left due to the eccentric jet towards the right atrial wall, or it can be heard at the apex, which will have radiation to the axilla. Another possibility, which is the second one, is a post-myocardial infarction ventricular septum defect. In this case, all the above named criteria have been met. In a large VSD, you will have additional splitting of the second heart tone as well as a pulmonary regurgitation sound or murmur. A tricuspid valve regurgitation does not look possible here due to the history and also lack of the respiratory variability, which is usually very well heard in tricuspid regurgitation. That's good. Now the next question is, what clinical differential diagnosis or disease condition must we think of? Well, with the history at hand, we must think of recurrent pulmonary embolism. What supports this diagnosis is the post-operative shortness of breath, the lightly raised heart rate, and the raised jugular venous pressure. Additionally, if there are no evidence or indications of myocardial infarction or pulmonary embolism, you really have to think of an aortic dissection. Okay, my next question is, if you do an cardiac marker enzyme test in this patient that had chest pain 5 days ago, what will you typically see, or what are you going to look out for 5 days post-myocardial infarction, for example? Well, after 5 days, typically I expect a raised troponin, because in the acute phase of myocardial infarction, the troponin you see in circulation are actually the cytosolytic troponin. They are usually regressed after 2 to 3 days. But thereafter, after 3 to 6 days, there's another rise in troponin. This rise in troponin is caused by structural damage. Additionally, you still have LDH, GOT, HBDH elevated after 5 days after myocardial infarction. The CK-MB fraction of the CK and myoglobin cannot usually be found at this time. Let me run how the cardiac markers when they appear in blood and their half-time. How long it takes to normalize. Myoglobin 2 to 6 hours, you see it in blood. Maximum 6 to 12 hours, and half time of 10 to 20 minutes. normalizes after 1 day. Troponin I 3 to 4 hours, maximum 12 to 24 hours. In vivo half-life 5 to 10 days. Troponin T 3 to 8 hours, maximum 12 to 96 hours. In vivo half-life 2 hours, and normalization 2 to 3 weeks. 5 to 10 days. Troponin I 5 to 10 days. Troponin T, you see it's 3 to 8 hours in blood, maximum of 12 to 94 hours. In vivo half-life 2 hours, and normalizes 2 to 3 weeks. CK, CKMB, GOT, HGH, LDH appear in blood 3 to 12 hours, maximum 12 to 24 hours. Half-life 12 to 17 hours, and they normalize 2 to 6 days. LDH 3 to 17 to 15 days. Okay. But I would like to say at this point that it is good to know that the kinesis of the cardiac ischemia markers is highly dependent on the type and time of the reperfusion therapy, as well as the size and type of myocardial ischemia. Okay, now you did an ECG where you saw sinus rhythm with indifferent axis, heart rate 62 per minute. There was slightly elevation of SC segment, maximum 0.2 millivolts in V1 to V4. There was loss of arrow wave in V1 and V2, and terminal T wave negativity in V1 to V4. They were also pre-terminal in 2-3 AVF, V5, V6. Your judgment is that of a front wall myocardial infarction with unspecific repolarization disturbances in the posterior back wall. You did troponin test that was 2.5 microgram per liter. Normal is below 0.03, so it's almost 100 times normal limit. CK was 189. You decided to give the patient clopidogrel in a loading dose and initiated heparin perfused, that is over syringe pump, and you did an echocardiogram. Here you saw a moderately reduced left ventricular systolic function with serious akinesia with some form of aneurysm at the heart apex, as well as in the mid-septal region. Lateral wall and basal back wall contracted, had good contraction. You saw in the FAB Doppler, you saw indication of a ventricular septum rupture in middle area of the septum with seriously left to right shunting. There was mild midrival regurgitation and mild tricuspid valve regurgitation with a maximum pressure gradient of 46 plus the raised jugular venous pressure, central venous pressure. The right atrium and right ventricle were dilated. Left atrium was also dilated. Left ventricle was normal. There was no pericardial effusion. So my question, what does one understand by a pressure balanced or a non-pressure balanced ventricular septal defect? Well, with the means of the color continuous wave Doppler in the echocardiography, you can measure the pressure difference in the left and right ventricle, so that you see if there's a pressure balanced defect or a pressure difference in the left and right ventricle. A small defect below 4 millimeters is usually because of the slow shunt volume, usually not pressure balanced. Contrarily, a larger defect usually have a raised right ventricular apex pressure and present with a pressure balanced ventricular septum defect. But what can affect these measurements are usually valvular, pulmonary aortic valve pathologies, as well as right and left ventricular pump failures. So let's carry on. Your patient remained hemodynamically stable. Under treatment of intravenous diuretic, she was able to make good urine, and she didn't have any angina pectoris. Do you think you still need to admit this patient into the intensive care unit over the night? Well, the truth of the matter is, every patient with SC elevation myocardial infarction, even if it is subacute, has to be admitted into the intensive care unit. And these patients with myocardial infarction ventricular septal defect, they belong to a very special high risk group with high mortality rate. In the Gusto 1I study, for example, patients with ischemic ventricular septal defect that were treated with just without operation had a 30-day mortality of 94%, compared to those that were operated that had a 30-day mortality of just 47%. About a quarter of the patients with acute septum rupture die within the first 24 hours, and less than 10% of these patients with acute septum rupture and less than 10% of these patients survive without operation up to a year. Apart from the post-infarction complications or ischemia-related complications like heart rhythm disturbances, you could also have complications from the VSD, which may be in form of surrounding necrosis of the unstable tissues around, that can bring to more rupture or multiple VSD. To plan the further management of this patient, you really need to do a cardiac catheterization. Okay, you did a cardiac catheterization. Here are the hemodynamics. The aortic pressure 114 to 64 to 84 millimeters of mercury. Pulmonary artery had a pressure of 62 over 20 millimeters of mercury. Right ventricle 62 over 18, and right atrial middle pressure was 14. Pulmonary capillary pressure was 15 millimeters of mercury. Oxygen saturation with 2 liters of oxygen in the right atrium 65, right ventricle 90, pulmonary artery 85, and pulmonary capillary 100, aorta 100%. The calculated parameters were the stroke volume, was cardiac output, was 2.96 liters per minute with a clearance of 1.73 liters per minute per meter square. The stroke volume was 35 milliliters when you have sinus rhythm, and the heart rate was 85 per minute. The peripheral vascular resistance was 2.162, and the pulmonary vascular resistance was 282. The pulmonary arteriolar resistance was 118 dyne per second per cm5, and the left to right shunt was 71%, calculated to be about 7.24 liters per minute. You did the coronary angiography. The main stem was normal, but you saw a functional occlusion of the LAD with delayed flow antegrade, being filled from proximal to distal. There were delayed antegrade filling because of multiple stenosis from proximal to the distal LAD. The ROCX had just some wall irregularities. ROCA had a proximal 70% stenosis. In the levocardiography, you saw akinesia of the front wall. Ejection fraction was estimated to be 42%, and there was contrast medium crossover into the right ventricle. So my question is, what general information are you going to bring out of this hemodynamic data? Well, from this data, I've seen normal systemic but significantly elevated pulmonary vascular pressures. You had lightly elevated pulmonary capillary pressure. The flow indices show a reduced stroke volume and cardiac output, as well as a reduced cardiac index. Additionally, we see indications of raised resistance in the small and big circulation, as well as a significantly raised pulmonary blood flow, which is here the QP/QS quotient of 4:1. So we are talking about a volume overload of the right ventricle. The consecutive volume overload from pulmonary artery and pulmonary circulation through the left atrium into the left ventricle is causing a reactive pulmonary wall resistance through contraction of the pulmonary arterioles. The reduced left ventricular pump function is primarily most likely due to a result of the ischemia, but has been secondly affected because of the high shunt volume negatively. Well, let me run the normal pressure values for you. Central venous pressure is supposed to be less than 10 millimeters of mercury. The right atrial pressure mean, that is middle pressure, is supposed to be less than 5. Right ventricular pressure is between 20 and 30. The right ventricular end diastolic pressure is between 4 and 8. Pulmonary artery systolic pressure is 15 to 30. The middle pressure is 10 to 22. And the diastolic pressure is 5 to 16. The pulmonary capillary wedge pressure is usually less than 12. Left ventricular end diastolic pressure between 6 to 12. The cardiac index is 2.5 to 4 liters per minute per meter square. Stroke volume is 60 to 90 millimeters per second per beat, and stroke volume index is 30 to 60 millimeters per meter square. The total peripheral resistance is between 900 to 1400 dyne per times S times cm5, and the pulmonary vascular resistance is supposed to be between 45 to 120 dyne times X times cm to the power minus 5. My next question is, what factors do you know that can affect the calculation of your shunt volume? Well, the shunt volume, amongst other things, is very, very dependent on the amount of hemoglobin you have in blood, as well as the number of cells you have in blood. You have false values when you have polyglobuli. The shunt volume that you need for this calculation, according to Fick principle, needs a mixed venous oxygen saturation and is dependent on the systemic blood flow. That means if you have a raised blood flow like tachycardia, you are going to see a correspondingly raised values for the venous oxygen saturation. Generally, any situation that can cause a change in the peripheral oxygen saturation or a change in the blood flow can have influence on the oximetry and therefore on the calculation of the shunt volume. So my last question for you now, it's not the last question. My next question for you now is, when is the optimal time to take out a surgical correction? Presently, there's no recommendation regarding the operation time, but what favors an early operation here is that when you wait, it can possibly come to a spread of the defect because of the unstable surrounding tissues. So because of that, patient with cardiogenic shock from a big or a large VSD should actually be sent for an operation in emergency operation. Additionally, an early operation covers, because of the still unstable ischemic tissues, the risk for a recurrent VSD, and that is associated with high lethality. So the time for the operation should be actually individualized and has to be discussed with the surgeons. So you did a transesophageal and transthoracic echocardiography where you saw findings of aneurysm of the front wall. How do you judge this? Well, about 60% of ischemic VSD rupture usually take place in the apical part of the septum. And these apical VSD are usually associated with aneurysm. Not only the aneurysmatic tissues, but also the surrounding myocardial region are usually found to become rigid, and they can, depending on the size, cause they can cause a rise in wall tension and affect the left ventricle end diastolic pressure. The resulting reduced contractility and progressive left ventricular dilatation leads commonly to a reduction in the heart's function. Other aneurysm related complications are thrombus formation with danger of an emboli, and also, which is not seldom or which is frequent, the presentation with ventricular heart rhythm disturbance, ventricular arrhythmias. So let's come back to our patient. Your patient was the surgeon took your patient and was given a combined bypass, ROCA, and a ventricular septum defect operation with ventricular reconstruction. Now, the patient presented 4 weeks after the operation with another chest pain, shortness of breath, and fever. In the test you did, which is ECG, echocardiogram, chest X-ray, you saw a significant pericardial effusion and also bilateral pleural effusion. My question now is, based on the history and these values, these findings, can you give a suspected diagnosis? Is this enough to give a suspected diagnosis? Well, the diagnosis here is the popularly known Dressler syndrome, which is actually a post-pericardiotomy syndrome. Etiologically, we suspect or an autoimmune background should be discussed. That means during the ischemia or operation, or during the operation, released myocardial antigens. Special local inflammatory processes cause pleural and pericardial effusion. In these cases, we usually find elevated anti-myocardial antibody titer in serum. There is usually a latent period of 4 to 6 weeks post-operatively before it occurs, but can also manifest after months. But I must tell you that in the last year, the incidence of this syndrome has reduced, not because of the optimal reperfusion strategy. Thank you very much.